This chapter is chapter 34, and this is care of patients with shock. The concepts within this chapter, of course, include perfusion and infection. The interrelated concepts are clotting, gas exchange, and immunity. Shock, the basis for shock may be evident from the presentation, such as when there's trauma or signs and symptoms of hemorrhage, fluid loss, or sepsis. A subset of shock patients will have normal blood pressure, maybe even hypertension. Many will also lack tachycardia. In such patients, the diagnosis can be challenging, especially since there is such um, individual variance in normal values for a blood pressure. Subtle or atypical presentations of shock may require a higher index of clinical suspicion. Initially, shock is reversible, but it rapidly progresses to cellular injury, cell death, and failure of critical organ systems, and then it becomes an irreversible state that terminates in death. Timely resuscitation can blunt that inflammation and the damage. This can potentially reduce the burden of early and late morbidity. Because delays in resuscitation can be lethal, shock demands prompt diagnosis and urgent resuscitation. It is a condition, it is not a disease in itself. So, our types of shock can be divided into four types: hypovolemic, cardiogenic, distributive, and obstructive. In a patient with a new onset of shock, you can usually tell what kind of shock you're dealing with because of their history and your exam. In a patient with shock, with distributive shock, you would see a high, wide pulse pressure accompanied by warm extremities and brisk capillary refill. That is evidence of a high cardiac output shock. Low uh, cardiac shock is seen with a narrow pulse pressure, cool extremities, and delayed capillary refill. That's a low cardiac output shock. This low or cardiac output shock is due to hypovolemia or due to pump failure, cardiogenic shock. In this subset of low cardiac output shock, you would do an assessment of the intravascular volume so that you could tell if they have hypovolemia or if it's from a cardiogenic reason, the pump's not working. So you might see bedside um, echocardiography done that should be performed to clarify or confirm the etiology of shock, and then that can identify treatable contributors, such as if they have a tension pneumothorax or a cardiac tamponade, or if they need fluid. So we can do all these things, and the treatment is based on what kind of shock we're dealing with. So, that said, let's look at these shocks. Hypovolemic shock is a medical emergency and should be treated immediately. You have to look for the underlying cause. This may include surgery or medicines to control bleeding or treatment for burns. Um, you may see the patho behind this. If you understand that, then you understand the symptoms. So if this is our circulatory system and the tank is our total blood volume, you could see if the tank is low. So what happens is that the blood enters and fills the heart. The blood that should be going in is decreased. And remember that that's called our preload. When our preload decreases, cardiac output also decreases, and our body has mechanisms that it uses to try to compensate. So you'll see a lot of vasoconstriction in the body because it's trying to push the blood back toward the heart. That means the pressure in our heart that our heart has to pump against will be increased. That's our afterload. But it also means that the blood flow has shunted away from non-vital organs like the skin, and that's why they get pale and cold. Then the heart rate will increase to compensate for the lower stroke volume. After a while, we'll begin to see our blood pressure decrease because the body can only compensate for so long. Ultimately, there's just not enough circulating blood volume to serve the whole system, and it will start to shut down. Causes are due to vomiting and diarrhea, volume loss, um, severe burns, fluid loss, traumatic injury causing hemorrhage, and you can have surgical and obstetric hemorrhage that can cause low volume. So we have stages of shock. Remember, in hypovolemic shock, we have a reduction in intravascular blood volume, which causes circulatory dysfunction and inadequate tissue perfusion. So we're going to talk about the stages of shock. You have the initial stage, compensatory stage, the progressive stage, and the refractory stage. There are volumes included in these, and stage 1, 500 to 750 milliliters of blood loss. Stage 2, 750 to 1500. Stage 3, 15 to 2000. And stage 4 is over 2000 milliliters of volume lost. In the initial stage of shock, you're not going to see a whole lot of compensatory things going on. The MAP, your mean arterial pressure, may decrease just a little bit to only by about less than 10 millimeters of mercury. You may have some vascular constriction and a little increase in the heart rate, but it's really kind of difficult to see these indicators of shock at this stage. It's very, very early compensation. They may be asymptomatic, they may have mild weakness, and they might be a little bit pale. But fluid loss can be either internal or external. So you're going to assess and monitor their vital signs and their level of consciousness. They, like I said, they may have early, they may have a little tachycardia and maybe a little tachypnea. In the compensatory stage, monitoring the vital signs could help to prevent the hypovolemic shock if you catch it early. And it can also help to determine the patient's response to treatment. So we're going to monitor the level of consciousness because it may decrease as the patient loses that oxygenation to their brain. Decreasing level of consciousness is a sign of advancing shock. The drop in arterial blood pressure will activate that compensatory mechanism. That's early on in shock. Then it will, because this is the compensatory phase, it will try to increase the intravascular volume. So the venous return, you will have diminished venous return occurs because of the decrease in that arterial blood pressure. Your preload will be reduced. The stroke volume will become decreased. The cardiac output is decreased because of that decrease in the stroke volume. The arterial pressure then is reduced. That mean arterial pressure will keep reducing as the cardiac output gradually decreases. Then you have compromised cell nutrients. As the tissue perfusion decreases, the delivery of oxygen and nutrients to the cell also decreases, and that can lead to multi-organ dysfunction syndrome. So you're gradually losing your perfusion, which is causing these compensation to increase, and the heart rate will become fast. It will be over 100. This is their stage 2 is overcompensation. They get very pale, anxious, and their urine output, they're not perfusing the kidneys. So their output will drop to less than 30 milliliters per hour. Now, the progressive stage, this is where shock is kicking in. The compensatory mechanisms are failing, and the patient is definitely in trouble. The sustained decrease in the MAP of more than 20 millimeters of mercury from your baseline. Their vital organs, the kidneys, the lungs, your vital organs, your heart, are becoming hypoxic. They're not getting blood supply. Some tissues will start dying. You'll have a rapid low pulse, low blood pressure. You'll see their blood pressure decrease, their heart rate increases, and their urine output will be low for sure. They'll be pale, clammy, and weak, and will likely have a decreased level of consciousness because of the lack of oxygen to the brain. So we're seeing this lack of perfusion to the kidneys and lack of perfusion to the brain. That's shock. The patient at this point needs intervention as soon as possible. The refractory stage. In this stage, you see a dire, life-threatening condition for the patient. Their blood pressure will be significantly low. Their heart rate and respiratory rate will be significantly high. The level of consciousness will be decreased, probably to the point of them being unresponsive. The pulse will be thready. They will be very pale, cool, and clammy, and they will likely have little to no urine output at this point because the lack of kidney flow, blood flow, is going to compromise the kidneys. Now you'll see that this stage is a fluid loss of more than 2 liters. The body only holds about 5 liters of blood. So this person has lost 40% of their circulating volume. If we don't restore the flow of oxygenated blood, this patient's not going to make it. So you're seeing evidence of cell damage, multi-organ dysfunction, the MODS. This is going to start releasing these toxic metabolites and enzymes. Inflammatory process will kick in. That rapid loss of consciousness, and they have just totally failed to compensate. They have worn their compensatory mechanisms out. Their heart rate's going to be over 140. The systolic blood pressure will be less than 90. A respiratory rate over 30. They may be in a coma, weak pulse, very pale, cool, and diaphoretic, and 0 urine output. So let's see the etiology here. In hypovolemic shock, the initial insult or the reason the organs aren't receiving oxygen is low blood volume. This could be because of a traumatic injury or hemorrhage, severe dehydration, or even burns can cause significant loss of circulating volume. If you can get the patho behind this, you'll easily be able to understand the symptoms. This is the incidence and prevalence is dependent on what's causing it. So we don't know what the incidence and prevalence is because this is not a disease. It is a response. It's a body's response to an incident. Well, let's look at health promotion and maintenance. Let's recognize our signs and assess and teach the patients about signs and symptoms of shock. You know, sometimes you'll see these things and you won't know exactly what's going on because there's no obvious sign of bleeding or anything. This actually happened to me once in a post-op patient. They seemed fine, vitals were stable, they were complaining of being weak, and they were a little pale. But I thought, well, you know, it's the anesthesia, they've had surgery, we just need to give them a little more fluid. Then they started to get a little anxious and their heart rate went up a little. But they were also in pain, so I just gave them some morphine. Next thing I knew, their heart rate was in the 120s, their blood pressure had dropped, and they were super confused. They had already pushed into stage 3 and were showing signs of shock because their brain wasn't getting enough oxygen. So I called the surgeon, and within 30 minutes, my patient was back in the OR repairing a bleed. So it's important that you know when your patient is at risk and recognize these early signs for what they are. We want you to catch it sooner rather than later. So this is important that you not only know the signs and symptoms of shock, but that you teach your patients about the signs and symptoms of shock. You need to know their baseline. You need to continue your assessment. You need to take care of these patients, most of which will be post-op patients or maybe sepsis, which we'll get into later. But you need to recognize the signs. Early recognition will save their lives, or at least stop complications that we can't correct. So, saying that, you need to recognize your cues. Your cues are the history. Know what your patient's in there for. Know their risk factors. Did they just have surgery? Were they in an auto accident? Or what illness are they experiencing? Are they throwing up? Are they having diarrhea? Was it trauma, procedures, chronic health problems? And know their urine output. This is critical. Urine output reflects your cardiac output. Physical assessment signs and symptoms include the cardiovascular, the respiratory, kidney, and urinary, skin, central nervous system, and skeletal muscle changes. So you're going to be looking at your patient. You're going to be watching them. That's why you're monitoring vital signs. Vital signs are not just there for you to do. Most times we're doing it for a reason, right? So let's think about that. Let's think about what we're monitoring our patients for. It can be all kinds of things can cause shock. We already know that. So let's be looking for this. And also their psychosocial assessment. You want to know what their cognition is, what their baseline cognition is. If you get them from the ER, you may not know what their baseline cognition is. If they're in the unit or if they had to go to surgery before you got them, but you need to know what their normals are. That's the main thing. So in hypovolemic shock, we're going to also do some labs because we want to know what's going on with the body. So if they're getting acidic because of oxygen loss or failure of perfusion to the organs, they may develop acidosis. So their pH may drop. So you're going to look at that. And you're going to look at their PaO2. They're not getting oxygenated, so your pulse ox is going to drop. Your arterial blood gas, your oxygen level is going to drop. They may have an increased PaCO2. They're retaining. So if we have recognized our cues, then we're going to be thinking about what do we need to do? What is our major goal here? And what are we going to be looking for? What are we trying to correct? We're trying to correct this inadequate perfusion due to active fluid volume loss and hypotension. That is what we are trying to fix. So, non-surgical management, of course, is going to include oxygen therapy. We need to give them some extra oxygen because their perfusion they're low on oxygen perfusion. They will need IV therapy, drug therapy, such as vasopressors, monitoring, hemodynamic monitoring in critical care, and then they may need, of course, surgical management. So the treatment plan, we always want to treat the cause. We always want to treat the cause. But either way, we need to replace the volume they lost. That may be by giving crystalloids, or it may be by colloids, depending on what the problem is. Sometimes we just can't replace fluids fast enough to support their blood pressure, so we may give them things like vasopressors while we work on replacing the volume. But it's important to remember that squeezing the tank does nothing if your tank is empty. So, the first thing we do is we start filling the tank. Also, because these patients are at risk for a decreased level of consciousness, they also may need to be put on life support to protect their airway. And of course, that depends on the situation. So let's focus on the top three concepts. The first concept is fluid and electrolytes, because the number one priority here is going to be to replace the volume that they lost as fast as possible. These patients are definitely at risk for airway and breathing issues, so we need to monitor their oxygen status and intervene if needed. When it comes to perfusion, we need to work to monitor and maintain their blood pressure. Surgical management would depend on whether or not they had a bleed or something they could correct. So, hypovolemic shock care and coordination and transition. This is a complication of another condition, and it has to be resolved before patients are discharged from the acute care setting. So remember, in hypovolemic shock, the initial insult is a low blood volume. It causes a decrease in the oxygen being provided to the tissues. After a large amount of volume loss, the body loses its ability to compensate, and they will progress into shock. So we want to treat the cause, and we want to replace the fluid volume they've lost and then some. We need to support their perfusion during this process, so we'll monitor them closely and maybe even start them on those vasopressors if necessary. But first we have to fill the tank. You can't push blood when there ain't no blood. So vasopressors are not going to help to begin with until you get some fluid into the tank. Keep your priority nursing concepts in mind and intervene as needed. And remember that this is an emergency. Recognize it and act quickly. You want to teach the patient's family and other family members indicators of shock. Increased thirst, decreased cardiac urine output due to decreased cardiac output, and lightheadedness. So that said, we need to evaluate our outcomes, and obviously our outcome would be, our goal would be to restore the vascular volume with normal tissue perfusion. That is our ultimate goal. Now let's talk about sepsis and septic shock. The pathophysiology in septic shock is that it is also a medical emergency. In most cases, these people are admitted to the intensive care unit of the hospital. Treatment may include mechanical ventilation, dialysis, drugs to treat low blood pressure and to treat infection and or problems with blood clotting, and high volumes of fluid may be given directly into intravenously, and of course oxygen. What causes sepsis? It's an infection. It causes tissue damage, organ failure, and death if not treated promptly, and it is pretty significant. Septic shock is a subset of sepsis, and it can cause systemic inflammatory response, and it can also cause multi-organ dysfunction. So these are both syndromes, and these need to be treated as part of the septic shock. So let's look at what happens in septic shock. Usually, and you look at this flow chart here, you have a local infection. Something causes you to have an infection, and it's not treated, or you don't realize that it's that bad, and then it becomes systemic. It gets into the bloodstream. So you have a systemic infection. That is early sepsis. Then you develop this inflammatory response related to that systemic infection. So you get a systemic inflammatory response. We know what the inflammatory response does, but think about that all over the body. So that's called SIRS. Then that can lead to organ failure. That is in severe sepsis. Multi-organ system failure, or MODS, is what happens in septic shock, and it leads to death. So absolute hypovolemia occurs when there's a loss of fluid from the intravascular space. This can result from an external loss of fluid from the body, or from internal shifting of fluid from the intravascular space to the extravascular space. Fluid shifts can result from a loss of vascular integrity, increased capillary membrane permeability, or decreased colloidal osmotic pressure. So they will have relative hypovolemia when vasodilation produces an increase in vascular capacitance relative to circulating volume. Now I want you to keep that in mind, because this is what can happen in sepsis. They can get this fluid can move from what the normal spaces into the intravascular, from the intravascular to the extravascular spaces. Now, they had this third international consensus definition of sepsis and sepsis shock. The Sepsis 3 defines sepsis as life-threatening organ dysfunction brought on by a dysregulated response to infection. It's a term used to describe a subset of sepsis in which circulatory, cellular, and metabolic abnormalities substantially increase the risk of death over that associated with just sepsis or infection alone. So sepsis is a systemic response to infection. It's manifested by two or more of the systemic inflammatory response syndrome criteria as a consequence of documented or presumed infection. Septic shock is associated with sepsis. So sepsis is one thing, but then septic shock occurs from sepsis. It is characterized by symptoms of sepsis plus hypotension and hypoperfusion despite adequate fluid volume replacement. So, etiology. It is a complex, extremely complex, systemic response that begins when an infectious organism enters the bloodstream causing an infection. You get pro-inflammatory and anti-inflammatory cytokines that are released. You remember that in the inflammatory response. And this activates the coagulation system that will form clots whether or not there is bleeding. The imbalance of the inflammatory response and the clotting and fibrinolysis cascades are critical elements of the physiologic progression of sepsis in affected patients. We call this disseminated intravascular coagulation. Annually, an estimated of 1.7 million adults will get septic, and about 750,000 of them will be in the United States. Elderly patients are more at risk for developing sepsis because of the decreased physiologic reserves and the aging immune system. So you're going to see this more in older patients. Usually it's a gram-positive bacteria that accounts for 50% of cases of septic shock, and it is also estimated that 20 to 30% with severe sepsis may never identify the site of the infection. So, sepsis and septic shock. Prevent. So, you are going to do a history. Again, you want their age, their risk factors, and what medications they have taken. You're going to do a physical assessment. Signs and symptoms. The criteria for sepsis is a temperature less than 96. So we're going to look at our cues. What are our cues for psychosocial assessment? Well, they're going to be restless, fidgety, they're going to be irritable. You're going to look at your lab tests. You're going to look at their lactate levels, their procalcitonin levels. You're going to look at their normal or low total white blood cell count. And you're going to look for those neutrophils that are new, rising band of neutrophil levels. And other various lab findings would include, of course, your electrolytes and renal function. So we're going to look at our cues and we're going to say what is going on here. That's where we're going to think, okay, sepsis maybe. We know what our cues are, so we're going to be looking for problems that can be causing this. We know that sepsis, we know that widespread infection because of their altered immunity can progress to severe sepsis with symptoms of organ dysfunction, hypotension, or hypoperfusion, lactic acidosis, oliguria, altered level of consciousness, and coagulation disorders, plus liver problems, hepatic function failure. So we're going to be looking for all of those dysfunctions and be looking for multiple organ dysfunction syndrome. So there may be altered function of one or more organs in an acutely ill patient, which would require intervention and support of those organs to get them back to homeostasis. So you've got the potential for this to happen. So the best thing to do is to recognize it early. I'm going to talk about this sepsis, what you would do. There are now general bundles that are used, and this all came from this Surviving Sepsis campaign. The current bundle is a 1 hour bundle, initial resuscitation for sepsis and septic shock. They're going to measure the lactate level. The lactate level should be measured first, then obtain blood cultures before administering antibiotics, and then administer the antibiotics and begin a rapid administration of 30 milliliters per kilogram of crystalloid, or uh, um, for hypotension, or for a lactate of over 4. Apply vasopressors if hypotensive during and after fluid resuscitation to maintain a mean arterial pressure of 65 millimeters of mercury. We've got to protect the organs. So broad spectrum antibiotics are administered within 2 hours of admission or diagnosis, and every hour that a patient is denied the antibiotic therapy, the chances of their survival is reduced by 7.9%. So this has to be done quickly. Prompt recognition and treatment will reduce in hospital mortality, and the 1 hour bundle is a cornerstone of sepsis quality improvement. So, taking care of these people when they go home. Sepsis and septic shock is caused by having an infection. So we want to prevent these shock episodes. You should instruct the patient and family about strategies to prevent septic shock or sepsis through identifying the factors that were implicated in their initial episodes. So you're going to do instructions on assessment. The patient should be taught about assessments and the need to identify the complications that may occur after discharge. Their treatment modalities. You must teach the patient and the family about their treatment modalities, such as emergency administration of medications, IV therapy, and parenteral or enteral nutrition, skin care, exercise, and ambulation. So, we want to evaluate our outcomes. We want to look at what we want from this, the outcomes of our treatment for this patient. You want to act quickly and recognize that the patient has sepsis and septic shock, and minimize the time to treatment. Sepsis and septic shock are medical emergencies. You want to monitor them closely for response to interventions, and communicate sepsis status in any handoff communications that you do. So let's actually look at a patient who has a problem. You have a 54-year-old male, 3 days post-operative following a colon resection. You have delegated to the assistive personnel, the AP, to obtain morning vital signs. At 8 a.m., the AP reports that the client's oral temperature is 101.8 degrees Fahrenheit. What is the nurse's priority action? Now, you've got to determine what you need to do. So let's look at this. You're going to go look at the patient yourself. This is your cue to go and check the patient. So it's your responsibility to determine what action should be taken next. You should do a complete assessment on the patient and determine if they need any of their antipyretic medications, or if the healthcare provider should be contacted. That will be based on your complete assessment of this patient. So you went in there and you assessed them, and you said, "Oh dear, they're flushed, they're diaphoretic, seems lethargic. He responds to simple questions. Vital signs are 92 over 42, heart rate is 132, respiratory rate is 28, and deep. His temperature has risen in this little amount of time to 102.6 Fahrenheit. Lungs are clear. The surgical wound has a dressing. It is moist, and it's got some purulent drainage. So how are you going to interpret this data? So you have your cues. You have a development of infection that should be considered based on this client's history. They've had an operation and their vital signs. He has tachycardia and increased respirations, as well as a moderate amount of purulent drainage at the abdominal dressing site. Surgical dressings should not contain purulent drainage. So, 5 minutes later, you go down there and you call the surgeon and you tell them what's going on. The surgeon prescribes Tylenol, 650 milligrams PO, PRN, Q6 hours for a temperature above 101 degrees Fahrenheit. Blood cultures times 2, taken 5 minutes apart. CNS of the abdominal wound drainage. Vancomycin 700 milligrams of IV piggyback over 1 hour every 24 hours. In what order are you going to implement these interventions? What do you do first? So this is the order that you would do it. You would first culture the wound and tell the laboratory that blood cultures need to be obtained. All this should be done before you start antibiotics, so get it done. Get it done quickly before you even start your antibiotics. Once that's done, then you're going to hang that vancomycin within an hour after the blood and wound cultures are obtained. Quickly. Then, at the very last, you're going to give them Tylenol for the fever. So first of all, you've got to get your cultures. Then, once they're done, you have to give the vancomycin or the anti-infective, whatever they order. So over the next hour, the client continues to decline with a decreased level of consciousness and a temperature of 103.8. Blood pressure is now 80 over 40. Heart rate is 134. Respiratory rate is 34. And the nurse calls the surgeon to report these findings and obtains orders for transfer to the ICU. When preparing for this transfer, the nurse notes that the client's O2 saturation is 87% on room air. So what is your priority action here? Get an ABG, apply oxygen, give them their acetaminophen again, or place them on a cardiac telemetry monitor. I hope to goodness you know the answer to this. Obviously, we are going to give this patient oxygen. He has a rapid respiratory rate and a low SaO2, so you need to give him supplemental oxygen. That should be the first thing you do. You will also address the temperature, and if it's me, I'd call that rapid response team to help them get to the ICU. Even though he's being transferred there, but he still needs to be stabilized. He is very, very, very ill. So you need all the help you can get. And here's why. Within 30 minutes of the client's arrival into the ICU, his condition continues to deteriorate. His SaO2 falls. The respiratory rate is now 36 a minute, and the ICU nurse notes blood oozing around the IV catheter sites. They put a Foley catheter in, and the urine output is minimal. So how would the ICU nurse interpret these findings? These are indications or cues that the patient is going into severe sepsis. The main signs are that low oxygen saturation, Q, rapid respiratory rate, Q, decrease to absent urinary output, another Q, and changes in their cognition. He is at risk for septic shock. The blood that's oozing around the IV may indicate that presence of the clotting problems, that disseminated intravascular coagulation. So let's look at these questions. I'm going to do these also because I think this is a very intense sort of lecture. Let's look at question number 1. So this question talks about a patient, a 39-year-old, is admitted for a severely abscessed tooth. The nurse assesses the vital signs. Blood pressure is 92/44, heart rate is 134, respirations are 26, and the SpO2 on room air is 90%. Their temperature is 38.9 centigrade. What is your priority nursing intervention? Priority nursing intervention for these things which are already ordered. So what's your first intervention? Your very first intervention. So your first intervention is to get some fluids, get an IV going on this patient, followed by their labs. You should get blood cultures second. This must be done before you give antibiotics. So get that done. Get them up there and get them the blood cultures drawn, and you should also provide oxygen. But your first intervention, first, you will do all of these, but because it's ordered, but your first intervention, your priority, your critical thinking intervention has to be getting a line open for these people and getting them on fluids. The blood pressure is fairly low. So now you're going, after that, you would get the blood cultures, their lab values done, and put them on oxygen while you're waiting for the lab to come. You will not start your antibiotics until they have drawn the blood cultures. And the Foley, the catheter can, of course, wait for a bit. So, when you're assessing a client who has been admitted for suspected sepsis, which finding does the nurse identify as the earliest sign? What is the earliest sign of suspected sepsis? Is it anuria, increased heart rate, decreased respiratory rate, change in systolic and diastolic pressure? The first sign, think about it. The earliest clinical signs of hypovolemic shock are cardiovascular, which includes an increased heart rate and respiratory rate. So you would have an increase in the respiratory rate and an increased heart rate. So your answer here is B. The reason that it goes up is to keep the blood pressure up. So changes in systolic blood pressure are not always present in the early stage because this is a compensatory mechanism, and it should not be used as a main indicator of shock presence or progression, changes in the blood pressure. Okay, this is early. Which assessment finding in a client in the refractory phase of shock requires immediate nursing intervention? Which assessment finding in a client in refractory, the late stage refractory phase of shock requires immediate nursing intervention. Warm, flushed skin, urine output of 20 milliliters an hour, increasing respiratory rate, or bleeding oozing from the IV sites. So we know that bleeding is a sign, especially at the IV site and other bleeding sites where they've been stuck before, suddenly starts bleeding or starts oozing. This indicates the onset of DIC, which is disseminated intravascular coagulation. This indicates a consumption of clotting factors that occurs in the refractory stage of shock. Okay, so this ends this chapter. Then the next chapter will be the final chapter in cardiovascular.